So now we're going to start talking about the modes of ventilation. So we're talking about how to intubate somebody who needs to be intubated, what an intubation is, what it looks like, what the complications are. But now we're talking about the actual ventilator itself. All right. So we're talking about the modes of ventilation. So we'll talk about all different kind of modes and which ones are kind of our go-to modes that we're going to usually be using all the time. All right. And you kind of want to know, across which ones are the worst modes, as far as not worst modes, but the worst modes where someone's in a lot of trouble, pressure control ventilation, versus someone that's in an SBT mode where they're just weaning, right? And that's actually called a pressure support ventilation. I have to pause to make sure I get them correctly because I honestly confuse them all the time too. It's like, oh no, that's support. That's supporting them from getting out, supporting them to get off the ventilator. Whereas pressure control is like you're in control, you're doing all the work for them. And then we have the middle of the road one, which is your PRVC, which we'll talk about. Okay. So your ventilator screen itself, we'll be looking at the ventilator screen. Flow, we're not going to be worried about so much, but pressures for sure. We don't want the pressure to get any higher than 30. Then we'll start getting concerned. Sometimes when we get to a really, really sick patient like ARDS, we'll tolerate all up to 45. We'll allow it to go a little higher, but we got to keep track of those pressures to make sure it's not causing more damage to the patient, like atelectatic trauma or barotrauma. Okay. Volumes, really we just need the readout of how much volume it is to see that it's, are we getting 300 cc's, 400 cc's? Are we getting what we programmed here, right? And RT, they like to switch it up, right? It's like a physics thing. So they either get tidal volume, TV. No, it's not anywhere on there. It's volume of tidal, right? And what's the respiratory rate? Nope, it's frequency of R, right? So it's sometimes you got to just kind of get oriented. Sometimes you can eyeball that number. It's like 22. That sounds like a respiratory rate. So you can see is that F or is it respiratory rate? It depends. Okay. PEEP is usually always PEEP, right? Usually a little plus in front of it, all right? And then FiO2 might be percentage. It might be a raw value like 0.7, or it might be 70%. And TI is your inhaled tidal volume. So we'll talk about what's inspired versus what is expired, right? And I can tell you if you are if you have a leak or not. If I deliver 400 cc's I inhalation and I get 300 E exhalation, those are both tidal volumes, right? That means I have 100 cc's unaccounted for. Did it escape from my ET tube, right? So you could have a leak. So that's one way to assess if someone has a leak. Okay. There's some maneuvers we can do, right? On the vent, we can do an inspiratory hold, we can do an expiratory hold, right? Expiratory hold is usually used for one situation. They have like auto PP and they're air trapping, whereas inspiratory hold is used kind of all the time to get our plats, right? So here's our pips up here. You got a plats that we can measure as well. These are all things that you can ask the RTs to get you because they know every 4 hours they have to look at the ventilator and write all these numbers down on the chart, and you can track and trend it as well. Okay, so waveforms, look at definitely the pressure waveform. Form waveform be a little bit, flow usually always the same, and then troubleshooting, pips and plats, and also like driving pressures as well. Driving pressures, and then ARDS. And ARDS is where we take all this stuff, which I know you might be learning for the first time, but we're going to kind of introduce you to ARDS because you do have patients that go into it. 4 years ago, everybody had ARDS. We had like 200, 300 cases per year of ARDS, whereas last year, like 5 to 10, right? Usually we have about 6 every year of like a really, really profound ARDS. I'm not sure the person is still here in 54, so she has profound ARDS. So that's someone we have to be then, we have to put on our chonies. We have to say, oh, we got to make sure the driving pressures are good, make sure we're reducing the tidal volumes, make sure we're increasing the PEEPs. We're doing all these things. We're in the FiO2 less than 60%. We got to make sure all these numbers need to be adequate because you are being trained to know what it is, and RTs, you know about what it is. And of course, your provider needs to make sure they get reminded too, because they also have like 18 other patients sometimes that they got to make sure that you are their eyes and ears at all times, right? And when you talk to the RT and they get your numbers, it may be a little bit confusing.
Hey Greg, how are the baby's vent settings? Well, I was able to adjust the unilateral phase detractors at 35 and the cardinal gram meters have decreased their output matrix to 4245. The last blood gas was good at 72560-256, but the retroencabulator parameters show a slight dip in the magneto-reluctant reactance.
I see.
The ET tube has an amulated wing shaft taped at 7.5, decreasing aerofabulation.
Well, that just makes sense.
Yeah, so ungular fumbling is also decreased.
Oh, good, that's good.
I've set the PEEP to the standard Lotus Void Del type setting.
Sure.
Now remember, every non-reversible seventh conductor tremor deviation needs to be monitored, so if fluoroscopic score motion is required, be sure they're deployed in conjunction with a drawn reciprocation girdle to reduce sinusoidal deplanaration.
That's just what I thought.
Okay, I've got some treatments to give right now. You'll be okay relaying this to the doctor?
Uh-huh.
No problemo.
So how's the baby's ventilator setting?
Great! They're great.
Why don't I go get the RT?
Oh, thank God.
Alright, so yeah, so there's a lot of numbers to be flailing around, but there's only a few that we got to be really paying attention to. Alright, so important equations. So RTs are all about this and knowing which equation is which. Doesn't really get us too much, is kind of explaining kind of how it works. But what's the point of all these equations? Basically, we're really focused on volume and pressure. And to give volume to something, the volume needs to flow over time, right? So I want to give this volume for 1 second, and it needs to flow to get a volume. So we can measure that. So there are flow waveforms, and we found that people like a flow that is nice and sharp, like really quick, right? We don't want to be like on the ventilator and be like a waveform that's like this, right? That's all the way slanted, because it's like, give me 400 cc's. Hold me just a second. 400, right? Then they want 400 right away. So that's it. With time and research, they said, oh, let's give them all. That's the kind of the ideal flow waveform we'll give them. And of course, when flow, you turn off the flow over a certain time, that's going to be no volume. So volume equals flow times time. So if time is 0, obviously there's no more flow anymore. But basically, volume is your tidal volume. That's what you're going to be looking at, and that's going to be changing based on the mode of ventilation we're on. Because sometimes we say only give volume up to a certain pressure, or only give volume up to a certain number. Right? So those are pressure control modes or volume control modes, which we'll talk about in the next slide. Okay, and then pressure. So how do you measure pressure? Well, what creates the pressure in the chest? Well, that's the tidal volume I'm delivering to the patient and the resistance that's pushing back, right? So that's all that's going to get my pressure. Now I'm going to get a peak pressure, right? The max pressure in the chest is going to be however much volume I'm giving versus how much resistance there is on the other side. That's the peak inspiratory pressure, or the PIP, right? We'll talk about PLATs, but PIPs and PLATs are the pressures in the chest that we don't want any higher than what number? Than 30, right? Yeah, an ARDS will let it slide a little bit higher, but usually less than 30 for everybody, okay? So what is resistance? That's the resistance to flow. So what is making it a bit difficult to get the air from the outside, from the air either in the ventilator or what they're breathing in, into the patient? It could be two things, right? It could be a really, really tight neck right here, right? So the neck of the balloon, or the bronchus is bronchospasmed, or there's food in the airway, there's maybe a patient already vented and they're biting in the tube. That's making it really difficult to get this air into the chest, right? My peak inspiratory pressure is high because the upper airways are clamped down. The airways are kinked. The airways have secretions. The airways are bronchospasm. The airways have angioedema, right? There's something in the way of getting the air into the chest, right? That is the resistance that's happening there. The other resistance that can happen, technically it's called compliance. It's the ability of the lungs to comply, right? So if your boyfriend says, let's go to the theaters, well, you gotta say, is the girlfriend complying or not, right? Are they going to comply? Are they allowing it to happen, right? Are we allowing the lungs to expand, right? So here's our lungs right here, right? Are they able to expand or not, right? So the ability of them to comply. If they have a huge ascites, can they comply with that tidal volume? No. If they have a pneumothorax on one side, can they comply with that tidal volume? If they have an effusion on one side, or pulmonary edema, or ARDS, are they able to comply, right? So that's the idea, that we have all this stuff that might be in the lungs, or externally there might be stuff in the way of the lungs expanding, like obesity. So that's what's causing the ability of the lungs to comply being more poor. So poor compliance is going to lead to a rise in your pressures in your chest, right? And we can tell which one it is. We can tell if it's an upper airway problem or a lower airway problem based on PIPs versus PLATs, okay? So PIPs versus PLATs. So PIPs are measuring resistance. Is there a difficulty getting the air into the upper airways, right? The PIPs can be high, whether it's a compliance issue or a resistance issue. But we can look at the difference. We say, hey, the PIP's high. Was it because of the upper airways? So I'm going to test it. I'm going to look at it. I can look at my end-tidal CO2 and see sharp waveforms. Oh, I'm going to give some breathing treatments, and look at those pips. It came right back down, right? It could be asthma. It could be secretions. It could be kinks in the tube. They're biting in the tube. That's increasing the pressure in my chest, and it's making my pips high because of that. On the flip side, there's plateau pressures, and plateau pressures are measuring, hey, once all that volume is inside there, once it's past the neck of the balloon, past the neck of the patient, once all that volume gets inside the chest, was it easy? That means they were able to comply. Or was it hard? They have obesity, ascites, effusions, tumors, they have all ARDS, pulmonary fibrosis. They have all these problems that are making it difficult for that tidal volume to equilibrate, right? So if they have all these things that are reducing compliance, that's going to raise the pressures in the chest. Yes, it's going to raise the pips, but I can put what's called an inspiratory hold on the patient and say, hey, I know the pressure's high, but what happens when I pause it and see what all the pressures are once everything equilibrates? So you can look at the difference in the pressures, which we'll point out. Okay, so you can see here's patient A, here's patient B, here's patient A, here's patient B. This is volume controlled ventilation on the left and pressure controlled ventilation on the right. So in patient A right here, that's normal, right? Flows nice and upright, perfect. We like that. We get a volume of 400. In volume control mode, you are in control of the volume. You say, give 400. And it says, aye, 400 cc's, right? You get that 400 cc's, you push that tidal volume into the patient, that's going to raise the pressures of the patient, right? So sometimes we have modes, older modes, the 90s that we use, that they raise pressures, and I guess that's a consequence of being on the ventilator, isn't it? But now we have smarter modes that will adjust the volume with every breath. It has a little flow chart inside of it, a little algorithm inside of it. We'll say, I accept your 400, but I'm going to give 300, and we're going to see how it works. And if I have a lot of room, I'm going to maybe go to 450, right? It's going to, every breath, it's going to adjust the tidal volumes. Okay? So you can see this patient here, patient B, is sicker in volume control mode. We programmed 400. We gave 400 because that's what we told it to do. But what happened? The pressure went up all the way to 35, right? Because they have an issue with compliance or resistance. We have to do a little maneuver to figure out which one it is. But the pressures rose in the chest because they have a pathology of some sort, right? So that's with volume controlled ventilation. On the flip side, we have a patient over here in pressure controlled ventilation, right? So we give a nice big flow, right? But we didn't tell it what volume to give. We told it, I'm gonna make the pressure and keep giving air, keep giving it until you hit 30. How much of that? It could be 1,000. It could be 200. It depends how sick they are. Again, if they have all these effusions, they have ARDS and all these things, you may only get 200. So this patient B is the sick one. Look how much they got. They got 300 cc's. We said keep giving air, keep giving volume, right? We're gonna crank the flow all the way up until you hit this pressure, right? We say go to a pressure control ventilation of 30. Don't go any higher than 30, right? And it's not a set it and forget it mode because you have to be alert to the volumes at all the time because the volumes could be going down when you set them flat and they're obese or they're pregnant or they are doing a bed bath and they're turned to the side and they're coughing. That's going to cause low volumes. Okay. So patient A though is healthy. You're going to get about 450. All right. Pressure control ventilation. You're only in charge of the pressure max in the chest. Okay. That's an overview of our volumes and pressures and modes. Now we're going to deep dive into each one. So again, volume control ventilation on the left here. There's a healthy patient. And on the right side is the unhealthy patient. There we go. All right, patient A, patient B. So in volume control ventilation, you're setting a what? A volume. A tidal volume, right? You say 400, 300, 600, 800. How do you know if 800 is good for them? And it's not. Usually not more than 550, 600. But how do you know it is the ideal tidal volume for them?
It didn't require a lot of pressure to deliver.
No, you can say, hey, that tidal volume we're giving them is causing the pressures to get high.
Ideal.
But how do you know that's the right tidal volume for them?
Ideal.
Must be very distant just written this down. Shoot. So how do you know it's high for them?
Based on their ideal.
Based on their ideal tidal volume, right? Which is your 6 to 8 mLs per kilo of their ideal body weight, right? Based on their height and birth gender, that's going to tell you if they are that tidal volume is good for them or not, right? So 6 to 8 is usually where everybody starts, right? So 6 to 8 per kilo is what we're starting these guys, so 6 to 8. mLs per kilo, and then that might not be adequate for them, or it might not be good enough for them. So meaning that it's going to cause like higher pressures, right? So we can back off from 6 to 5 to even 4 mLs per kilo if we need to, especially the ARDS patients. When we give that tidal volume inside the chest, that's going to start raising the pressures when we have a sick patient right here, right? We have a sick patient that's going to start raising the pressure in the chest. So we have to be always alert to our peak pressures. And that's going to let us know if they are tolerating the tidal volume or not, if we need to adjust things. Okay, so example modes, we got assist control, we got CMV, PRVC, SIMV. The one we use always is which one? Pressure regulated volume control. That is the GOAT, all right, the greatest of all time. That's the one we're going to be using. It's a smart mode. It will adjust the tidal volumes based on the pressures you're getting. That's why it's called pressure regulated volume control. Okay, so example settings, like we mentioned before, this usually gets used by about 90% of the time. Just start with all 5s. And then you calculate exactly what their ideal tidal volume should be. And then they might need more FiO2 or less FiO2. You might need, if they're breathing 20 beforehand, 15 might cut it. If they're breathing 40 beforehand, 15 is not going to cut it. All right? Yes?
PRVC is the same as ACVC.
PRVC, ACVC, so we'll talk about that with the Dragers and the servos. So it's a trademark thing. So this Servo Maquet has trademarked PRVC, and they don't want anybody else to have it. It's like trademarking NIBP, and now everybody else has to use effective arterial blood volume instead, right? So it's like, what are you talking about? That's what it is, blood pressure. No, I trademarked it. If you use it, you have to pay me, right? So it's a whole thing, okay? So what the Drager calls it is autoflow assist. That means nothing to me, right? what is assisting? Okay, everything has flow. That doesn't tell me what. But PRVC tells you exactly what it's doing. Okay, so when you read these settings, you're saying PRVC, rate of 15, 500, PEEP of 5, 100%. Okay, and now back to pressure control ventilation, right? So our pressure control ventilation patient, there's a patient you're setting a target PIP. You're saying don't let the pressures in the chest get any higher than 30, for instance, right? Don't go any higher than that. But we have to be alert to the volumes going down, because if they have a lung that is filling up with fluid or a tumor or a fusion or something, you're going to have a lot. Yes, you can go up to 30, but there's other stuff in the way, right? So when do you use this? Usually when you have poor lung compliance, when you have really high plats, right? They need to be sedated and paralyzed. That's usually where we're going over to these pressure control ventilation modes. Right, and we'll touch base a little bit more on these, but basically you're setting a target pressure that you don't want to go over. So pressure control at 20. That means don't go any higher than 20, right? And then respirate rate of 16. Are you setting a volume? No. The volume is going to be generated based on the pressure control. Just like BiPAP, you say go from 16 over 10, right? Or 16 over 5. So start at 5 and go up to 16. However much volume you get is however much you get, right? So that's why BiPAP is similar to pressure control ventilation. And how do you read it? It's pressure control 20 over 5. That's your PEEP right there, right? So 20 over 5. So that's basically like you're reading a BiPAP setting to somebody, right? Rate of 16. In this case, this rate is having a change in their CO2. It will change the CO2 when you change the rate here, and of course your FiO2. All right. So volume control ventilation. So what is going on? So we are delivering a volume when we detect them breathing. Just like BiPAP, when there's a little bit of inhalation, it's going to deliver a breath. If the inhalation doesn't happen, it's still on a time cycle. It says, I got to deliver 16 breaths a minute. If they don't breathe exactly before that point, it's going to, here's your volume. So sometimes you can see a little inspiratory effort from the patient, and sometimes you don't, right? Because it depends, it's going to be assessing at all times, is there a little negative inspiratory force happening, and am I going to support that? Or is there nothing, and then I'm going to breathe at whatever the user told me to breathe at, okay? So you can see here, we're going to ventilate. So you see a little inhalation right there, right? A little inhalation, a little patient's inspiratory efforts, and then it's going to deliver 400 cc's, right? So now picture here is volumes, which you're going to deliver 400 cc's of volumes, and that's going to reach a certain pressure. We don't know what pressure it's going to meet, but it will meet a certain pressure, and that's what we're keeping an eye on, is the pressures at all times, right? And the patient's efforts are supported with some volume control modes, and sometimes they're not, right? But in this case, it detected a little breath If the breath didn't come, then it would automatically just give you a breath, and you won't see that little dip in the baseline. And then we have a finish, right? Where it comes back down to whatever PEEP I set, right? PEEP of 5, PEEP of 10, PEEP of 12, right? It goes up to a certain pressure. We don't know what it's going to be, but it's going to deliver 400 cc's, 450 cc's, 6 to 8 per kilo, and then it's going to come right back down to the PEEP that I set, right? So that's why the waveform looks like that. Okay, and if you pay attention that your diaphragm goes down and it's going to accommodate this positive pressure inside the chest. Okay, so the patient's efforts are being supported by the vent, right? And sometimes the vent's in full control, and we need to provide sedation to kind of kick off the to help oxygenate the patient. Okay. So volume control ventilation, again, volume is controlled. All right. There's such thing as time, flow, and such. Like when you learn from an RT's perspective, they're always looking at all four of these things. Like I mentioned, flow is always constant, right? We want to make sure, if your flow is not there, you're not getting volume. That just makes sense, right? But the time can be adjusted, and we'll touch based on changing the times for inspiration, expiration, right? Usually you breathe about, 20 breaths per minute, right? So you're just 1 second in, 2 seconds out, all right? That's 3 seconds. If that 3 seconds is your inspire, expire effort, that's 20 times per minute, right? 3 times 20 is a minute, right? So you can change that though. We can make it 1 to 3. We can make it so they exhale longer, right? Of course, that's going to reduce your respiratory rate. So we can change those things to affect our respiratory hemodynamics. But again, volume is controlled here, right? We set the volume, and that's going to then create a pressure inside the chest. Okay, so we can see that the pressure can go up when they have pathology, or it can just be normal. We see PIPs less than 30, beautiful, that's perfect, right? And again, we have increased resistance or decreased compliance. That's going to start increasing the pressure in the chest, and that's going to start causing the rise in PIPs and plats. And we have to figure out why it's happening. Do they have increased secretions? Do they have an effusion that we can take, do a thoracentesis for? Is there something else we can do? Okay, so then pressure control ventilation. So what happens in pressure control is we're setting what? Setting the pressure you want to go. You want anything higher than 30 or 40 or 20. Right, it's up to us to figure out which one it is, right? Some patients, they like it better and they want 20, but usually this is used for the sicker patients when it is 35, 40, 45. All right, so here we have pressure control of 35, so not going to go any higher than 35. Respirator 22, so it's delivering this 22 breaths a minute, cycling on and off, on and off, on and off, whatever that is, right? Whatever factor, that ratio that is, of 1 to 2 seconds or 1 to 2, right? It's going to, then the ventilator's smart about it, and it's going to adjust the timing for that. So it'll be like 0.7 in, 1.2 out. It's going to adjust it to whatever respiratory rate you set. All right, and then PEEP of 15, right? So we're going to start at 15, and we go all the way up to 35, right? And then go back down to 15, up to 35, down to 15. And that difference there, you don't want to be too high. That's called the driving pressure. You don't want that to be too high, otherwise that's going to start causing atelectic trauma. So when we talk about ARDS patients, we want to make sure we're really cognizant that that's not too wide of a value. Okay, so here we have our patient's efforts here. So it will detect their little inspiratory efforts, and it'll support it, right? And then it will stop supporting it down to whatever PEEP you set, right? So airflow is allowed to come back down to baseline. Okay, and this difference here again is our driving pressure. That's our driving pressure when we talk about driving later, and we go up to a PIP of 35, whatever we set, right? And for measuring plateau pressures, that's the next step. But this is you can see that the PIPs, they can. That's great. We're going to 35, not more than 35. But again, if they start getting more and more pathology, you're going to start having changes in your volume. So it's very important to monitor volumes. And if you have an end-tidal CO2 in place and your volumes are getting lower and lower and lower, what do you expect the end-tidal CO2 to do? Not drop, but elevate, right? End-tidal CO2 is going to start going up and up and up and up as your volumes are less and less and less. That's another reason why it's important to have end-tidal CO2s in place. Otherwise, you're waiting for the AM ABG at 5 a.m. and you get an ABG of like 120. It's more times than not when we put patients on pressure control ventilation that we see, the CO2 just jumps dramatically because we can't monitor it beat to beat. So you don't have a lot of safety net with pressure control ventilation.
So this is 35 or 15.
Yeah, so that previous mode would be for 35 or 15, pressure control for 35 or 15. All right, so pressure control ventilation, again, we're setting the pressure, okay? Not letting anything go less than that, and then when we're done, because we time cycled it, say if we want 22 breaths a minute, it's going to go on, off at whatever ratio that is for a rate of 22, okay? And then the flow, don't worry about the flow, all we gotta know is that, patients like it when they get all their volume at the beginning. And then the volume will fluctuate. So that's why we wanna make sure we're monitoring at all times. Your tidal volume is less than 250, your risk for your CO2 going up. Your minute ventilation starts going less than 6, your CO2 is going to start going up. So we want to make sure that we are keeping an eye on these two things. Okay, so you can see here we got a great lung. We set it at 35 or 30, 25, 40, whatever it may be, and we got this volume. But that same 40 is not the same for every patient. This patient here might have, let's say, a pleural effusion, right? That's filling up all the right side, right? Because they have, or say the left side because they have pancreatitis, or all the right side because they have a hepatic hydrothorax from liver cirrhosis. That's going to be causing a lot of problems and increasing the ability of the lungs, decrease the ability of the lungs to expand, right? Increase the pressure in the chest. So yeah, we said don't go higher than this number, but you're going to suffer in the volume category. All right, so again, overview. So here's where we start with everybody. Everybody starts at which mode? PRVC, right? And we'll talk in the next two slides why AC and CMV are not great. But PRVC is where we're going to start. That's everybody kind of starts right there as the middle of the road. And we assess, are they getting better or worse? If their PIPs and PLATs start getting worse and worse and worse, we're saying, hey, don't go any higher than 40. All right, I'll accept 40, right? Because 30 is where I'm really concerned, but no higher than 40. Once you're in the 50s, you start getting pneumothoraces, right? But no higher than 40, so we'll do pressure control ventilation, okay? As a patient is clinically worsening usually. And if they're getting better, they're going to start going the other direction, right? They're going to start going this way, and then they can even go into a weaning mode, where you're doing an SBT of some sort, a spontaneous breathing trial, where you're saying, hey, you're doing great on PRVC, let's see how you do on your own, right? And these are weaning modes. And the best one is pressure support. Here, colloquially, we always say, put them on CPAP, CPAP. They're on CPAP, you're on CPAP. Are you on CPAP? And no one's on CPAP, I promise you, right? That's not the mode they're on. They're on pressure support ventilation, okay? And we'll point that out. And SIMV was retired in the 90s. You might see some people that get it for hiccups. You might see it for like rarely here and there, but it's not a mode that's utilized, okay? And then volume control ventilation. Again, we are setting the volume, we're setting the tidal volume. And what are we watching in the meantime? When we set that tidal volume, you're watching the pressures, right? Especially if you go old school in the 90s, and you start using CMV or AC, right? Because these ones definitely are going to peak your peak pressures, and it can definitely put you at high risk for barotrauma, right? But with pressure regulated volume control, this is the best of both worlds. The RT sets their high pressure alarm limit to like 35. So it won't deliver, it's almost like you're setting a pressure control mode. So don't go any higher than 35. I don't care what volume you have, and you're going to hear your alarms going off, and it says pressure limited, because it hit the alarm. It's just like your heart rate going off at 120, right? It's going 120, 120, 120. So what do? Change it to 130, right? So that's exactly what the RT does. They come in there, you say you're doing a bed bath, they see you're laying flat, you see you got a big patient there with ascites, hepatic hydrothorax, and they got this and that side, they got bilateral pneumonia. Let's go ahead and raise the peak pressures to 40. That way they get some volumes during your bed bath, right? And then when you're done, they're going to go back in there and they can set the pressures back down, right? Just like your patient's going to AFib RVR, it's in the 140s, you give diltiazem, you bring it back down, you're going to bring your heart rate alarm back down to where it should be, right? The same situation. So PRVC is a great mode in that respect, in that you can set a high pressure limit, whereas you can't do that in CMV and AC. And then we have straight up pressure controlled ventilation. That's where you have a sicker patient with really high PIPs and PLATs, and we don't want it to get any higher. And we kind of we pump the brakes and say no higher than 40. But we have to be alert to what other value? Their volumes, right? Because they're going to have variable tidal volumes. It could be from 150, even down to 60. I've seen it's like we switch patients from PRVC to pressure control ventilation, and we're getting like 60s, 70s. And the CO2 is going up, their oxygen's going down. Why is the oxygen going down? Because you're only delivering 60 cc's of 100% FiO2 compared to 400 cc's of 100% FiO2. Obviously, one person is getting more oxygen than the other. Okay, and then we'll touch base just a little bit on airway pressure release ventilation, APRV. That's usually the new kid in the block the last 10 years or so, and that's actually a great mode, but it's really complicated, and nobody understands it. All right, so it's but it makes a lot of sense. And then we have weaning modes. There's a patient that's getting better or worse. Yeah, patient's getting better. We're putting them on a weaning mode. And the weaning mode you're putting them on is pressure support. No one's going to SIV and no one's going on CPAP. And please don't let them put them on TPs. That's just cruel. Okay, that's technically a weaning mode, but it's not a mode because they're off the ventilator and they're just breathing through a straw at this point. Okay, so I want them tough and strong. I want them, if they can breathe through this, they can be extubated. But they found that, they compared the two. With the pressure support, where it's like or helping them out, like you're giving all the welfare to everybody, and it's helping. They figure, oh, that's, we should be able to do. They should be toughened up, and they found that patients that did the TPs died more than patients that did pressure support. All right, so it's better to do pressure support, and it's better to do it for 30 minutes, not 2 hours. All right. So volume control modes. So we got our sys control, we got our CMV. And again, these are retired, right? So you should not see these anymore, except for in the Draeger, because the Draeger couldn't copyright PRVC in time. All right, so it's a continuous mandatory ventilation. This is where the patient is, you deliver breath, you set the volume, 400 cc's, 500 cc's, rate is 16. Patient's like, hey, can I breathe? Nope. Honey badger don't care. All right, you're not getting a volume. No matter what, continuous mandatory ventilation, you're 16. Don't care. Right? There's no utility or clinical situation where this would be appropriate. There's no, this is an old mode, right? So CMV is where you say give 400 cc's tidal volume, no matter what. Don't care what the patient's doing. All right? Patient breathes 30 breaths a minute. You can see 30 little inflections on this little line right here. But the ventilator is going to be delivering all the volumes. It's taking over. Okay? So patient effort does not care much. Right? Care much, very. I don't have a good analogy for that one, a mnemonic for that one. And then assist control. So assist control is where you set a volume, right? You set 400 cc's, 500 cc's in this case, and it's going to deliver that tidal volume, 500 cc's, no matter what. Doesn't care what the pressures are. Say pressure is 40, too bad, 500 cc's. That's what you told me to do. It's very facetious. It's like a 10-year-old. It's like, yeah, that's what you said. You said 500. I gave 500. Why are you mad at me, right? So that's what it does. Give us 500 cc's no matter what. That's fine if someone's breathing like 16 and they have no other lung pathology developing. Then yeah, that's fine. But what if they start getting agitated? You put them in a breathing mode, or sorry, you start doing a bed bath, and they start breathing 500 cc's at 36 breaths a minute. That's a lot of volume in that chest, and that can be a lot of air trapping. That can lead to a lot of problems, right? So they're going to be pelted by assist control, right? So that's not a great mode. Risk of hyperventilation and barotrauma for sure. Okay, so does it support the patient's effort? Yes, it assists every breath they take, right? That's a song, isn't it? So yeah, so it's assisting every breath they take, and it's going to, no matter what, they're breathing 30 or breathing 10, it's going to deliver every single breath, depending on what your rate is, of course. If your rate's 16, it's not going to deliver 10. It's going to deliver 16 no matter what. But they breathe 20, it's going to deliver 20 breaths at 500 breaths, every single one of those breaths. So what's the GOAT? What's the one we want to use every single time? All right, that is our volume control mode known as PRVC. All right, it's a volume control mode, but it's pressure regulated. It's going to say, I see that you want to give 400, right? You want to give 400, but you know what? I'm going to give 300. We're going to try 300 first. I appreciate you. I understand you. I respect your decision making, but I don't trust you. So I'm going to give 300 cc's, and it's going to measure 300 cc's, and it's going to say, hey, the pressures are super high. I told you, right? So it's going to go back and give 250 cc's, right? It's going to deliver that in the next breath. If that 250 cc's causes a lower pressure, say, oh, I got room now. I'm going to go to 325, right? So it's a smart algorithm. So it's going to adjust the tidal volume with every single breath. Okay. So the RT sets of course, the volume and the mode, but they also set the rate, right? Usually 30, 35, 40, and it will intelligently adjust the tidal volume based on what pressure they set. Okay. If the pips are too high, the next tidal volume is lower. If the pips are too low, the next tidal volume is higher. So I say, hey, I give 400. Why are you giving 450? Because you got a lot of room. You made a mistake, right? So you have the ability to adjust that. Okay, we can adjust this pressure limit. Okay, if they need a lot more volume, right? We can, because they keep hitting the pressure limit. They keep hitting 35 every single time. We can change it to 40 so we get a better volume, just like in our pressure control modes.